Just bear with me one moment. Well, good evening, everybody, and welcome to this webinar. I'm going to start the conversations in about 1 minute's time. We've got a number of participants just arriving at the moment, so please settle down, and I'll start talking in just a couple of minutes. Well, good evening, everybody, and a very warm welcome to this webinar. My name is Marcus Green. I'm the Chief Executive of Action on Preeclampsia, and it's my pleasure to be chairing this along with Professor Andrew Shannon this evening. Before we get underway, just a few thank yous and a few notices. First of all, this is a Zoom webinar, so if you can't see yourself on the screen now, it's because you're not one of the delegates. You are one of the delegates, rather. So delegates, you will not be able to see yourselves, or your camera or your mic will be working. Neither will be working. We would encourage questions. We want to hear your questions throughout the evening. So please use the Q&A function at the bottom of the screen there. And you'll be able to put your questions to us. Later on in the evening, we will be taking questions across the panel, so you're warmly welcome to use that. So first of all, before we get underway, just a few thank yous and a bit of housekeeping. This event has been put on at the request of NHS England, who approached Action on Preeclampsia and NCT to do this. And we're very pleased to have done this. In terms of APEC events, this is the largest event and the largest gathering of people that we've ever had on anything that we've ever done. So the interest is huge in PlGF at the moment. It's entirely appropriate. It's entirely where people are at. And we are looking forward to sharing more with you as we go through the evening. We've got this wouldn't have happened if it hadn't been for the help of a number of people. So I'd particularly like to thank Rowan and Abby in the APEC office. Particularly like to thank Jennifer from NCT, who will be coming in a little bit later, and also Natalie from NHS England for pulling this all together. So thank you all very much. I think it really doesn't leave me with very much more to say, other than as an organisation, Action on Preeclampsia is very much in favour of PlGF implementation. We are entirely agnostic on which company is used. We do not take a position on that. We regard that as a decision for clinicians and a decision for commissioners. So it's a local decision, and all companies with NASA at the moment are ones that we work with and would endorse their work. So without any further ado, I think we'll hand over to our Commissioner, Natalie Carter, who's Patient and Public Involvement Manager in the Innovation Research and Life Sciences Group at NHS England. So I will hand over to her and I will just begin the screen sharing. So hopefully you should be able to see that. Natalie.
I can't see the slides yet. I can see your screen, Marcus.
Okay, bear with me.
That's okay.
Right. So that should be working for you. If you want to talk through to your slides, just bear with me 1 second. Yep, that should now be working for the audience to be able to see it. If you've got your slides, I can move them on as we go along.
Okay. Can the audience see the slides?
Can see.
Yes, they can.
I can.
Okay. Okay. I'll speak to my slides. Okay, so and I would like to thank everyone who's joined this call this evening. I would like to thank APEC Action on Preeclampsia and the National Childbirth Trust for co-hosting this with us, and all of the speakers and organisations and patients who
Right, we seem to have lost Natalie, unfortunately, for a second. Hopefully she'll be back in.
I'm not sure what happened there, but I've reappeared. So
Okay,
I was
welcome
just
back.
I was just thanking APEC and the National Childbirth Trust and all of the speakers and patients for joining this evening. So I'm Natalie Carter, the Patient and Public Involvement Manager, and my introduction is very brief, just to give a bit of background about what medtech products are and what the medtech policy is, and then I'll be handing over to a patient guest speaker and some experts who will be talking in more detail about placental growth factor based testing. Next slide, please. Thank you. Oh, so I'm going to be talking about what the medtech funding mandate is. So it's an NHS long-term plan commitment to get selected NICE, and that's the National Institute for Health and Care Excellence, approved cost-saving devices, diagnostics and digital products to NHS patients more quickly. So diagnostics, many of you on the call might know that that's a form of diagnosing something, and we're going to talk about a particular diagnostic in more detail tonight. And when we say NICE approved, Rowan from APEC can share a link to the actual policy, but what we mean by approved is, so it's NICE approved, but within the policy guidance, the products that are selected to be a medtech product need to be affected according to the NICE medical technologies guidance. They need to deliver material savings to the NHS. So benefits of the innovation have to be over £1 million over 5 years for the population of England, cost saving in year. So a saving has to be demonstrated within the first 12 months and affordable to the NHS. So the budget impact should not exceed 20 million in any of the first 3 years. So what else is the medtech funding mandate? It's a policy document ensuring that clinical commissioning groups, otherwise known as CCG, funding for selected products, which essentially means that it's a policy that enables healthcare providers to make this available to NHS patients. So the clinical commissioning group would make that funding available to NHS trusts, for example, so the product would be funded to reach the patient. And in terms of how we actually implement this policy across the NHS, we have a network of 15 academic health science networks who are local delivery partners across England. And We have Guy Checketts talking later on from the AHSN who will talk about that in more detail. But our team is very much behind the scenes at the policy level, and the academic health science networks are very much at the forefront of the implementation. So what are some of the benefits of the policy? And I'm referring to the 2021-22 policy. So some of the benefits for patients are hospital avoidance, reduced length of stay, closing the gap on inequalities by ensuring that proven innovative treatments are available to all. And the criteria for the 2022-23 policy, which comes into effect on the 1st of April, has been slightly reduced so that more products will be supported by the policy. So in our first year, we had 4 products supported, and in our next year, there'll be 7 products supported. And what are the benefits for the system? And I mean the healthcare system. So it helps with recovery from COVID-19. It helps to accelerate, so speed up the uptake of proven affordable technologies. Available on supply chain, removing need for individual procurement contracts. So there's more detail of this in the policy that can be sent out, but it means that the product is listed in some of those national NHS product catalogues, so it's not like doing an individual procurement contract. Full implementation of this policy, so that's across all 4 medtech products for this year, brings a net saving of 25 million over 5 years to the NHS, and it delivers an NHS long-term plan commitment. So that is a very high level overview, and as I mentioned, Guy Checketts from the AHSN will go into a bit more detail later on. So I will hand back to Marcus.
Okay, thank you very much for that. That was really helpful. We're now going to hand over to Thasha, who is going to be telling us about her experience with preeclampsia. So Thasha, I shall hand over to you.
Hello, so my name is Thasha Baskulingam, and I gave birth to my son on the 20th of November 2020 due to severe preeclampsia. So here's my story that I'm going to share with you all. So my pregnancy started off, I had a healthy pregnancy. My blood pressure was continuously monitored at every midwife appointment, as well as my urine being checked for protein. Everything was fine. However, I did get slight swellings in my fingers and in my legs. However, it was nothing that kind of was alarming to my midwife, kind of to link it to preeclampsia, because my blood pressure was still normal and I did not have protein in my urine. It was all okay up until my 32-week midwife appointment. That's when my midwife noticed that my blood pressure was increasing and I had protein in my urine. That was when I was rushed off to hospital. And again, my blood pressure was monitored over an interval of time, as well as my urine being checked, and I was diagnosed with severe preeclampsia. During that time, it was during the COVID pandemic. So my specialist midwife was like, okay, because I'm not seeing any spots. I didn't have the symptoms of like so much swelling and having pain and feeling nauseous. I didn't have any of those symptoms. I appeared healthy. My blood pressure was around 140, like maybe 145 as a maximum. So it wasn't too high either. So we were questioning of whether I needed to be admitted or not. And that's when my specialist midwife said that there was a new test that was out, and that was the PlGF test. And she said if it did flag up, it would mean that most women that have such results end up delivering around 10 days of that mark. So yes, mine did flag up. That was the test that basically saved the life of myself and my son, because that's the test that determined that we needed to be admitted and that I needed to deliver my son within 10 days, and I did end up doing that. So from a patient's perspective, the test was the test that saved both of our lives, and I'm happy to take any questions hereafter. Thank you.
Thanks very much. If I can just say, we very much love to hear questions. If you wouldn't mind putting them into the Q&A, then we will address them towards the end of the meeting. So thank you very much for that. I'm now going to hand over to Jonny Myers, and I will just get Jenny's slides up.
Good evening, everybody, and thanks, Sasha, for that lovely perspective from your, from having lived experience of this and needing the test and understanding and appreciating how the test made a difference to you. And I think that's what it's all about, isn't it? Understanding how this test makes a difference to the women who are suffering from preeclampsia. And I think it gives that clarity of information to everyone looking after you, and it obviously you found it beneficial and helpful during your journey. So thanks for sharing. So I'm Jonny Myers. I'm an obstetrician in Manchester, and I've been involved in research related to PlGF and its use for the diagnosis of preeclampsia for some time, and have been very involved with Manu in terms of helping hospitals around the country to implement PlGF-based testing. And I'm going to give you a bit of background on PlGF-based testing, and also a very quick overview of what's been happening in the Northwest in Manchester, where I work. Thanks, Marcus. So a lot of clinicians ask me, next slide, sorry. A lot of clinicians ask me why we need a diagnostic test for preeclampsia, because we've been making a diagnosis of preeclampsia in clinical practice for many, many years. It's sometimes the diagnosis, we don't need a new blood test to make that diagnosis, and there are still a lot of women who will present with high blood pressure and protein in the urine where the diagnosis is clear. But there are many women where the diagnosis is not so obvious, and that's women who are developing gestational hypertension, which is where the blood pressure goes up at the end of pregnancy, but they're actually not developing preeclampsia. And in that group of women, the test is extremely useful in reassuring them that even though their blood pressure's changed, they're not actually developing preeclampsia. Presentations of preeclampsia often don't read the textbooks and are often atypical. And we set arbitrary values for all of the clinical signs: preeclampsia, blood pressure, protein in the urine, and that sometimes can make the diagnosis challenging, because blood pressure varies so much day to day, hour to hour, and so does the protein levels in the urine can also vary day to day. In women who have chronic medical conditions such as high blood pressure, diabetes, kidney disease, making a diagnosis of preeclampsia is actually really very, very challenging without the addition of the PlGF test, because it's actually very hard to distinguish preeclampsia from underlying medical disease. So a quick schema of how these biomarkers fit into the pathophysiology of preeclampsia, which is a condition which is caused by damage to the placenta. And many years ago now, next press enter, Marcus, please. Some studies demonstrated that there was a hormone called soluble FLT, which was expressed at very high concentrations in the placenta of women who had preeclampsia. And that led investigators to look at whether this marker was in the blood, enter Marcus, and again, and in this very famous study, they demonstrated that soluble FLT levels were dramatically increased in women who developed preeclampsia, and women who had preeclampsia also had very low levels of another hormone called placental growth factor. So low levels of placental growth factor and high levels of soluble FLT seem to be very consistently shown in women who were developing preeclampsia. And that's over nearly 2 decades ago now that those research studies were shown, and we now know an enormous amount more about these biomarkers and how they fit into the disease. Enter Marcus. And again, and we now know that these biomarkers are released by the placenta and contribute almost certainly to many of the signs and symptoms that we understand as being part of preeclampsia. So low levels of PlGF and high levels of soluble FLT almost certainly contribute to the high blood pressure, the leaky capillaries, which cause the proteinuria, and the activation of the lining of the blood vessels, which causes the deranged blood tests that we see in preeclampsia. Next slide, Marcus, please. So following on from that original research, there were two very big studies which demonstrated that these biomarkers were capable of identifying those women who were developing preeclampsia, and importantly, those women who were going to develop complications associated with preeclampsia. And on the back of those two big studies, next slide, Marcus, please, the NICE Diagnostic Assessment Panel, having reviewed those two big studies, decided to recommend the use of PlGF-based testing to rule out preeclampsia in women who were presenting to maternity services with a clinical suspicion of the disease. And that guideline actually came out in 2016, and it's it illustrates how long it takes to drive change within the NHS. Even though there was a NICE guidance, because the test costs money, it takes quite a while to get it adopted into routine clinical practice. Next slide, please, Marcus. And so following those guidelines, actually two randomized controlled trials were performed. One, the Parrot UK trial, which was a step-wedged RCT in 13 maternity units across the UK. Manu also performed a trial in Oxford, and both of these trials have generated enormously useful evidence in terms of how we actually use the test and how it makes a difference to clinical outcomes and to both maternal and perinatal outcomes when we implement the test in routine clinical practice. So in the Parrot study, there was no increased risk of, or no increase in iatrogenic preterm delivery. So we weren't delivering babies dramatically earlier as a result of the test, which means that we were using the test sensibly to guide clinical management and delivering women when they needed to be, but we weren't delivering everybody as soon as they had a test done, which was very reassuring. And we also showed a significant reduction in adverse maternal outcomes. So although those outcomes are rare in the UK, using the test demonstrated a significant reduction, 20% reduction in the rate of adverse maternal outcomes, presumably because we were watching women much more closely and delivering them when they started to develop severe complications associated with preeclampsia. We also got more steroids into women in a timely fashion, and that study showed that using PlGF-based testing was cost effective. The INSPIRE study showed very many of the same outcomes, and one of the most important outcomes from the INSPIRE study was that the number of women who were admitted wasn't grossly different between the groups, but the women that were admitted when we used the test on top of clinical judgment were much more likely to develop complications, really illustrating that we were getting the right women onto the right surveillance pathways. And I'm sure Manu will say more about that in a moment. Next slide, please. So across the Northwest, I was happy to be involved in implementation really from the get-go in terms of implementing PlGF-based testing in hospitals across the Northwest. And I'm hugely grateful to many of my obstetric and midwifery colleagues across the Northwest who really worked very hard to make this happen for pregnancies across the Northwest. Next slide, please, Marcus. So there were a number of things that had to be done in order to implement at a regional level. We had to get some additional midwifery time to help with implementation. We worked very closely with our AHSN to support implementation across the network. We also involved the Strategic Clinical Network and the local maternity systems networks, so that we were really trying to provide a joined up approach to implementation across the region. We also had a hub and spoke model, recognising that in hospitals with lower numbers of maternities, the frequency of the test would not be as high, and therefore it's more expensive to implement. And so our central lab run the test for many of the, or for some of the hospitals around the region. For other hospitals in the region, they were able to put the testing into their hospital labs, and we were able to help each other with troubleshooting, and the labs worked together to make the best solutions that worked for their local systems and their local populations. We had to make some adjustments to IT to make sure the tests were being appropriately reported in a timely way. And we had kind of monthly meetings with all of the interested parties to keep updates on progress and to be kind of regularly reviewing how we were going in terms of implementation. Next slide, please. And this is a very messy graph, but it just illustrates that we were able to track the number of women that were having the test performed in our hospitals across the region. And we were also able to detect when hospitals were perhaps doing fewer tests than we would expect them to do, or maybe more tests than they were really should be expecting to do. And in the situation where they were doing more tests than we thought they should do, we were able to kind of put in some more education, go back into the unit, spend more time with the doctors and midwives, and maybe understand why they were doing more tests than they should be. And so all of this implementation is critical on appropriate education to ensure that the doctors and midwives who are using the test understand when it is useful and when it's not useful. Next slide, Marcus, please. So we also across the region did some auditing, and we had just a very basic data collection tool to help hospitals look at their outcomes from the women who are having their testing. And I'm just going to share with you a couple of highlights from our own hospital at St Mary's Hospital in Manchester. Next slide, Marcus, please. So during the implementation period, 18 months worth of data from St Mary's Hospital, which is a large tertiary hospital in Manchester, we did about 1,000 tests in about 680 women. And about a third of the women that we did the test on ultimately had a diagnosis of preeclampsia, which is very similar to the rate of preeclampsia in the Parrot study. In this group of women, we had about 150 women who had early preeclampsia before 37 weeks. And we were able to look at the number of babies in that group who were appropriately prepared for delivery. And those women where steroids were indicated before birth, 80% of them got them in a timely fashion. And magnesium, which we all know, helps to protect the baby's brain if the baby is needing to be born preterm. In women who had a normal test, we only had one maternal complication, whereas the vast majority of maternal complications, as you would expect, were in those women who had an abnormal PlGF-based test, in this case, the soluble flip PlGF ratio test. And also, although we did have some perinatal losses in women with very early preeclampsia, we had no perinatal losses or no stillbirths in babies that were over 26 weeks and which were of a viable weight. And I think that is not to say that that's all down to PlGF-based testing, but when you're doing education around preeclampsia and you're implementing a new test, there's a lot of focus on the condition, and you can really notice that people are perhaps learning from that, and we're getting the right women and babies into hospital for the appropriate monitoring, the appropriate action. We also wanted to make sure we weren't having any harm associated with PlGF-based testing, and we looked at our hospital level data, no increase in iatrogenic or overall preterm birth as a result of PlGF-based testing, which is really important, and a hint that we were certainly not having a detrimental effect on perinatal deaths following implementation. Okay, last slide. Thanks, Marcus. So just a quick mention of the Parrot Island study, which is a study that was published last year, which didn't confirm benefit of PlGF-based testing. And so understandably, people have been concerned about why the Parrot Island study hasn't supported PlGF-based testing in the same way that the two previous randomized control trials did. And there are some really, really useful clinical lessons from this in terms of how we use the test. And the biggest difference between the Parrot Island study and the Parrot UK study was the number of women in the study who had high blood pressure. And actually, the average blood pressures of the women in the Parrot Island study were significantly lower than Parrot UK, and over 50% of women in the Parrot Island study actually didn't have high blood pressure. They entered the study because there's a suspicion of a small baby rather than of a change in maternal condition. And despite that, the populations being very different, although the results of the Parrot Island trial weren't statistically significant, the signals all went in the right direction. And actually, the trial didn't recruit as many women as it had initially hoped to do, 57% of the initial sample size. So really important data from the Parrot Island study, which really confirms previous work that's shown that PlGF-based testing is really at its most useful in women who've got hypertension or other maternal features of preeclampsia. And it's not a test that has the same value in babies where the presentation is an isolated small gestational age. And that's really important to make sure that we're doing the test in the right women to get the maximum clinical impact. Next slide, please. Okay, so in summary, we're going to hear a bit more about adoption across the UK. I hear it's now about 85% of maternities in England now have the option of having a PlGF-based test if it's indicated. Our experience is that there's a very steep learning curve in terms of using the test properly, and we're learning more and more all the time about how we should use the test. As I've already said from the Parrot Island study, absolutely essential that we use the test in the right women. And PlGF-based testing identifies a group of women who are at risk of developing maternal disease related to preeclampsia, but it very much needs to be used in the context of our clinical judgment. And it certainly will catch those women who are developing preeclampsia, and that's not to say that there aren't lots of other important complications of pregnancy that we also need to consider that won't be captured by the test. Thanks very much.
Thank you very much, Jenny. That's really interesting. And I think we're now moving on to Manu. Got the right slides. So Manu, over to you.
Okay, thanks. I feel slightly redundant now that Jenny's given so much data around, so I apologise if some of this is repetition. My name is Manu. I'm an obstetric consultant at the John Radcliffe, and next slide. And if you can click 4 times, Marcus. Another time. Thank you. So just the overview of some pathology here, that we know that the preeclampsia, the pathology lies in the placenta, and some insult occurs to the placenta in the early pregnancy. And then in the latter half of pregnancy, you get the manifestations of disease and preeclampsia, growth restriction, preterm delivery, abruptions, and uterine death. And this disease it affects blood vessels. You can see the kidneys at the bottom, other organs, and there's been a lot of thought and a lot of attention. And Jenny mentioned the 2 molecules that were identified as being released from the placenta, soluble FLT and PlGF. And I'm not going to go over that data because Jenny's done that so elegantly. The objective of my talk is to talk about the Oxford experience. So if we go to the next slide, I can tell you the clinical situation before we had angiogenic biomarkers. There were a lot of admissions for people who we thought might have preeclampsia, and many patients were admitted for several days. And either we made the diagnosis or we said we didn't think they had preeclampsia. And of course, everybody spent time on a smartphone, and they sat there and they said, "Are you sure?" If you said, "I don't think you have it," "Are you sure?" And at that time we couldn't be 100% sure, or couldn't be at all as sure as we are now. Admitting these patients for so long used a lot of resources: CTGs, blood tests, midwife time, ultrasound, bed space. Sometimes we made the diagnosis incorrectly, so we thought somebody had preeclampsia when they didn't, or sometimes we didn't make the diagnosis quickly enough. And as Jenny mentioned, it's really difficult to make a differential diagnosis if you've got comorbidities and like somebody with chronic renal disease. And then not to forget that there's anxiety in the whole process for both the mum and her family, and disruption, because there's disruption from not being at home, and there's disruption from not being at work for many of the mums. Next slide. So I was involved in one of the biggest studies at the beginning, which was prognosis, the other one that Jenny wasn't involved in. And so this was a large multi-center international study, which looked at 1,273 patients. And essentially it was asking 2 questions. Could you use soluble FLT and PlGF as a ratio to exclude preeclampsia, or could you use the test at a different level to predict preeclampsia? So if we go to the next slide. essentially, the study derived a cutoff of ratio of 38. And if you had a ratio of 38 or less, then you could rule out preeclampsia for that woman when you saw her and for the following 7 days with a 99.3% negative predictive value. And, you know, this comparatively to what we were doing before was quite extraordinary. This study was done retrospectively. It was a retrospective study. We collected the patients, collected the data, we did the tests, and then we retrospectively looked at it. And nobody had done it to actually intervene with patients. And so we moved on to the next slide, which was the INSPIRE study, which Jenny's mentioned, which was the alternate study to Jenny's. And this was done in Oxford. And it was basically an interventional study using the ratio soluble FLIT and PlGF in women who came in with suspected preeclampsia, and then we were using it to triage what happened to them. And if we go to the next slide, what it did was, using the ratio, change the pattern of admissions. So you ended up with more high-risk women being admitted and less low-risk women being admitted. We ended up with an immediate diagnosis in the assessment unit, and we were getting results. We were initially getting results within an hour, and now we're getting them within the same time frame as the routine blood tests. This allowed us to focus the use of our resources, so we were admitting not more patients, not less patients, just the right patients. And that meant that our CTGs, our midwife time, blood tests, and ultrasound were being used more efficiently. It was massively helpful in the diagnosis and presence of comorbidities. And we showed that if you used a cutoff upper threshold of 85, so 38 and below to rule out and 85 and above to rule in, the positive predictive value was nearly 72%. Giving a number to people decreased anxiety. It decreased anxiety for the mums, but it also decreased anxiety for the doctors, because you could do a test and with a large amount of certainty say that I don't think you're going to get this disease, whereas before it was, I'm pretty sure you're not going to get this disease. There's less disruption, of course. The little pictogram on the right basically shows that if you use a soluble FLIT PlGF ratio, what you do is you admit you never send a high-risk patient home, basically. You admit all the patients are going to get preeclampsia. You don't admit very many low-risk patients. And conversely, you send home a lot more low-risk patients. And in our trial, we didn't send home any high-risk patients. Next slide. So we had a problem then, which is we had to implement. And so we had a test, we wanted to implement it, we've done trial, and we identified there were 3 separate areas that we needed to highlight. And that these were biochemistry and liaison with the biochemistry department, education, and funding. So if we move to the next slide. Next slide, please. Thanks. Oh, no, go back one. Thank you. So we were very fortunate that we had a very friendly biochemist called Tim James. And what he did with us was, when we did the trial, he said, I've got a pretty strong feeling we're going to be using this clinically because it sounds so good. So he actually did the trial and processed the samples as if he was implementing a new test, which meant that he did a standard operating procedure for samples, turnaround times. He looked at sample stability, and we integrated the results into our electronic patient records for the study, which meant that when we were going to implement the test for routine practice, all this background work had been done. And indeed, we published what samples you need to use if you're going to use this properly. Next slide. We made a protocol for Oxford to start with, and this was a protocol that we put up in the hospital to start with, and then we adapted it for COVID because we knew that we could keep patients away from hospital and they didn't need to come into hospital. So we increased the gestational age that we could use it to 36 weeks and 6 days for COVID. And then we started talking to Guy Checkitts and Julie Hart at the AHSN Oxford to talk about network-wide implementation. So I'm not going to talk about that because Guy's going to talk about that. But the next thing we focused on was education. And if you go to the next slide, we spent a long time trying to educate people. So on the left-hand side, you can see the clinician. We made we wrote lots of reviews in different journals for different readerships that would capture most people who might use the test. In the center, the studies that we did to prove that the soluble FLIT and PlGF worked. We did systematic reviews of PlGF on its own. We did systematic reviews and meta-analyses of soluble FLIT PlGF. On the right, where you can see the dollar signs, we recognized that people were always going to talk about dollar signs, so we did health economics reviews. And then we started to roll out the study and try to help other countries to implement the test. And so we've implemented the test, or helped implement the test, in South Africa. Sophia Sedera has helped to implement it in Japan. We've got an implementation in China and in Nigeria, as well as in Portugal. Next slide, please. So as Jenny mentioned, we have a NICE approval. So if you click about 4 times, because it'll just stop me having to, that's it, thank you. So as we mentioned, NICE approval, we had to make a local business case, which we made successfully in Oxford in 2018, and we started using the test in October 18. I'm not going to have time to talk about this now, but it's completely arbitrary how one hospital and the hospital adjacent to it looks at the way you cost things. And it was a real eye-opener to us that in the same network, different hospitals would look at cost savings in different ways. We talked to Guy in the AHSN in Oxford, and as Jenny mentioned, the NHS Accelerated Access Collaborative gave us the titles of PlGF-based national champions. I like the word national champions, but PlGF-based national champions was a bit of a mouthful. But we had the ability to try and talk to doctors, midwives, clinicians all over the UK, and try and, when they were uncertain as to whether the test would be useful for them. And we could do that in a pretty independent way. The funding has come through and it's approved for use in the NHS. And I won't talk more about that because Guy's going to talk about it. So if we move to the next slide, I think it's pretty obvious that the standard clinical assessment of preeclampsia is poor. And basically my view is that any angiogenic biomarker test is better than standard clinical practice. The evidence is pretty strong across the board, and we should encourage use of the biomarkers so that's the first thing we think of doing when we think of preeclampsia. We should try and help to implement this type of testing in parts of the world where maternal mortality is a bit higher. Next slide. I just want to make a final shout out to Sophia Sedera, whose picture is in the center at the top of this. Most of the work that you see underneath has been spearheaded by Sophia, and Sophia has actually taken this as a trainee. So she started this work as an ST2 and she's just entering at ST6, and she's shown real commitment to try to get this test rolled out, to try and educate people about this test. And I don't think I could fairly talk about what we've done without mentioning her. Thank you.
I should know to unmute my own screen. Thank you very much. I am now going to hand over to Guy, but if you can just bear with me 1 second, because I've misplaced Guy's slides. There we are. Yep, there. There we go, Guy. Thank you. I'll hand over to you.
Thank you, Marcus. So good evening, everyone. My name's Guy Checkitts. I work for Oxford HSN. And as Manu just said, originally started this work with Manu and Sophia and their team in Oxford, looking at the uptake and implementation of PlGF-based testing. But for the last 3 years, I've been the national HSN lead for the Spread and Adoption project for PlGF-based testing across England under a programme of work that's been sponsored and supported by NHS England. And what I'm about to take you through really sort of ties together the threads that have been introduced by all the previous speakers. So I'll just start by giving you a quick overview of the HSNs, who we are, what we do as a network, and then reiterate just some of the key points about the PlGF-based testing itself and the benefits both to pregnant women and the NHS as a healthcare system. And then close by talking about how we went about delivering the project, and the its current level of how it's made available today within the NHS across England. So we can go to the next slide, please, Marcus. So for anyone that doesn't know, the HSN Network, the Academic Health Science Network, was created by NHS England back in 2013 with the purpose of transforming lives through healthcare innovation adoption in the NHS. So we essentially spend our working lives working with the NHS, with innovators, bringing in new products, new technologies that help improve the work that the NHS does. There are 15 HSNs across England, and we work locally, regionally and nationally together to help with the development and the spread and adoption of new technologies. So we have three main aims: improving the health of patients, driving economic growth within the system, and saving money in the delivery of health and care within the NHS. And together in this instance, we've worked collectively to drive the adoption of PlGF-based testing across maternity services in England. Next slide, please, Marcus. So again, to reiterate some of the points that have previously been made, obviously PlGF-based testing, it's a simple blood test that helps clinicians in the diagnosis of preeclampsia. And under the NICE guidelines, Diagnostic Guidelines 23 from 2016, specifically, that's a rule-out test. So as Manu and Jenny were saying, it gives the clinical teams a very high degree of confidence that with a negative result, they can safely send the woman home with very little risk to them with that negative result from the test. And there are actually two companies currently recommended under the NICE guidelines. One's Roche Diagnostics, the other a company called Quidel, and they either measure one or two of the two biomarkers that have been mentioned, the PlGF itself and the SFLIT, that individually or together help indicate the health of the placenta. And there are a number of benefits for both the woman, her family, and the healthcare system as a result of doing the test. Obviously, patient safety is very high on people's agendas, as you've heard, helping with clinical risk reduction. And as previously been said, depending on how the pathway is set up, that result of that test can be available within as little as an hour. So it can be a very quick turnaround to help with the speed of that diagnosis and rule out in the negative cases. And as I think Manu said, the rule-out test is very important. It helps keep women out of hospital, has been very important under recent times with COVID and so on. But the flip side of that is it means that those women that do need maybe extra care and support can actually get that because of the positive effect that's had on the system in terms of resource and capacity management within the maternity service itself. So it helps deliver the right care to those women that need it most. And the next slide, please, Marcus. So just finally from me, just to talk about the project itself and how it's currently available. So as we've said, it's been a national project since April 2019. And really delivered as a partnership between NHS England, the manufacturers themselves, the HSN Network, and as Manu said, Jenny and Manu as our clinical champions have been absolutely invaluable in helping spread the word and give that peer-to-peer support to trusts and maternity services that are going through the process of adoption. So collectively, we've worked with the maternity services themselves, help them identify their local need, understand their pathways and how the test can be inserted into that pathway, often needing to modify the pathways to get the best value out of them, and then really supporting them through that adoption phase, the manufacturers providing the product training and so on. And then going from obviously when they deliver the first test up to standardizing it into clinical practice within the maternity service. And during the course of the project, funding was mentioned previously. The test itself was actually directly funded by NHS England through the Accelerated Access Collaborative for the first 2 years of the project. That's now changed, as Natalie was introducing earlier on, into the medtech funding mandate, which is part of the commitment under the NHS long-term plan, and means that commissioners are obliged to provide funding for the test for those maternity services that want to offer it. If anyone on the webinar is still going through the process of thinking about adoption, as AHSNs, we're still here to support the project. So if you have a need or questions, please reach out to your local HSN, and we're more than happy to help you with that. And then, as Jenny mentioned earlier, we're really pleased to say that something like 85% of all pregnancies now have a PlGF-based test available to them as and when required as a result of this project. So it's been tremendously successful, and couldn't have been done without the help and the support and the input of all the parties involved. Thank you, Marcus. You're on mute, Marcus.
Thanks, Guy. We're about to have one final presentation in a moment from Lisa Beaumont, which is about to come up in a second. But what I did want to say is that we are looking for your questions. We're going to open up after this session 2 questions and answers, and the panel are all very keen to fill you in on any questions. So please use the Q&A function to ask any questions. And we will endeavour to get to as many of them as possible. But in the meantime, I am going to hand over to Lisa to hold on my screen.
Hi.
There we are, Lisa.
Okay, hi. I'm Lisa Beaumont, and I'm currently working within the Innovation Research and Life Sciences Group for NHS England as a patient, lived experience and marketing advisor. And my lived experience on this project is relevant because I would be, well, about 18 years ago, I would have been a candidate to have the PlGF test, because I was admitted prior to delivery with suspected preeclampsia, and in the end I didn't have preeclampsia and I had a healthy delivery, no problem. But it would have been so good to know that that was the case if there had been a test to rule it in or rule it out, because I had a younger daughter, or I had another daughter already, so I had to leave the little one at home whilst I was admitted, waiting for the second one to come. So it was quite disruptive, as was said earlier, that any test like this that can help to rule in or rule out the condition is going to cause much less disruption for patients and their families. So my involvement with this particular project is because I'm helping to support some of the medtech funded projects within the Innovation Research and Life Sciences Group. So I have been undertaking a task called social listening on behalf of this project, which is where I do a review of all the activity that's available to be found on social platforms, because social media platforms are a fantastic way of being able to hear directly from patients and families about their experience of whichever medical condition is under the scrutiny at the time. So I was able to have a look for any references to PlGF that I could find online and capture those user experiences on a whole range of platforms, including Twitter, Facebook, Instagram, and LinkedIn. But in the process of the searching that I do, it allows me to find all the reports that have been shared on a topic. So effectively, it becomes a bit like a news review process, whereby I can report back on how much information is out there in the public arena for people to find about a topic. So that's what I've been doing on this project, but particularly focusing on patients and charities this time. Okay, so next slide, please, Marcus. Okay, so on this project, there have been a lot of posts to find, largely because APEC itself has been very active promoting this webinar. So there was lots of information out there to be found. And also the charity Tommy's had done a lot of posting about the Parrot trial when that was underway. So there was a lot to be found. And then on the professional platform like LinkedIn, there was lots of coverage from the likes of Andrew Shannon and also from digital health publications, where there have been articles about the project and the product that are available for people to read about what it is and how it works and how they can get hold of it. So there's quite a lot of coverage on LinkedIn, but overall I'd say that the coverage I found is mainly from professionals and clinicians and organizations, rather than, it was hard to find any actual patient stories. So it's so good to hear Darshia's story earlier, but those are the kinds of stories which is likely will be shared online in due course, but just haven't been yet on this. Okay, next slide, please. Okay, so what I was able to find, there was a lot on Twitter, because Twitter is often used as a platform where people share links to complex papers. It's a very good place to find information, or where journalists look for information. And then on Instagram, there was only a very little on Instagram, but the references that were there were from hypnobirthing trainers and other registered midwives and other medics who were keen to share the new news. In particular, there's a doctor, she's calls herself Mummy Medic, and the Mummy Medic shares bite-sized information about new developments that are going to affect expectant mothers, and she particularly wanted to share what she knew about the PlGF, so that her followers, of which she has many followers, so that they would be aware. So that's a good example of how social media can really help to spread the message for a new development like this, and also allow the patients themselves, in this instance the mothers, to become familiar with the possibilities of a new test. So they might potentially ask their midwife or their hospital clinician if they can be tested, if they've heard about it online. So online is a very useful place to be sharing the information, because it gets consumed by the people who actually need to know it, the patients themselves. And on Facebook, it was mainly posts that have been led by APEC, although there were some other charities like the Birth Trauma Association. And otherwise, again, it was the professionals and the midwives posting about it on Facebook. But there were certain private groups where there may be groups of mothers who have had the test, but it's in a private group, so you can't go in and see what they talk about. So there will be people out there talking about it. It's just that I couldn't see what they were saying in this instance. So that leads into one of my recommendations at the end, is how you could get more feedback if you are looking for more feedback from patients over time. Thanks. Next slide, please. Yeah. Yeah, so in terms of my recommendations for this project, I would say that if you have some clear objectives as to what you want to find out from social media, you could really use it as a source for finding things out. And if you want to find out experiences of mothers, it would be perfectly possible to set up a private closed Facebook group where you could ask those mothers who's had the test to give their honest reviews of how it helped them and whether it saved them disruption by knowing it was ruled in or ruled out. And it would be quite easy for a charity to approach its members and its followers through newsletters and so on, to invite people to join a closed group, and then in a group you could share opinions and experiences and find out quite a lot direct from the horse's mouth. So that would be one of my suggestions leading out of the work that I've done. Yeah, so overall, I think I would say that I found that the social listening work showed that social is actually really relevant for this development and could deliver some cost-effective insight of how PlGF is being used in practice. And it may well be something which would be worth pursuing in future.
Okay, thank you very much, Lisa, for your contribution. Right, what we're going to do now is bring all the panelists back in, so cameras on and microphones ready, and I'm going to hand over to one of my colleagues. I'm going to hand over to Jenny Holly. Jenny is research manager at the NCT, and she's been instrumental in working to make this a successful day. So Jenny is going to look after the questions and answers. We've had quite a number of questions, so thank you for those, and probably enough to keep us going for most of the rest of the night. So I'll hand over to Jenny. Thank you.
Wonderful, thank you. It's been really interesting listening to all the presentations this evening. We do have quite a few questions. Clinical focused questions. First of all, a question about there's concerns over long-term health of baby born to the early term at 37, 38 weeks. Is there a role for using PlGF in women with hypertension until 39 weeks to help with decisions about timing delivery, or is there not specific evidence about that? Wondering who to direct that to. I don't know. Jenny's smiling at me.
I was actually smiling because I thought I was going to suggest Manu, but I'll say my two penny worth, and Manu can chip in. So as well, that there is, you know, nothing stops with a line in the sand. So at the moment, the evidence is that the test is useful in women who present at less than 37 weeks. There are undoubtedly some women where the test is useful beyond 37 weeks. But the distinction between the biomarkers in women who are developing preeclampsia and women who aren't developing preeclampsia, the kind of difference in the biomarker levels is not so great in pregnancies after 37 weeks, and therefore the ability of the test to really for certain rule in or rule out the condition is not quite so good. And we haven't got evidence from the trials because none of the trials included women beyond 37 weeks. So there will be individual circumstances where the test would undoubtedly be very useful in those later gestations. And we would all really, really love a test that was able to really help make guide delivery decisions after 37 weeks. But at the moment, it's not likely to be PlGF-based testing, because I think its ability to discriminate between high-risk women and those women not at risk after 37 weeks is not going to be quite so good. Manu, would any more thoughts on that?
No, I think that's a reasonable summation. I think the honest answer is nobody's looked, and so and because nobody's looked, we've not got a reference range. We don't know what normal is and abnormal is, and so really we should look.
Thank you very much, both. I think, Manu, I might be coming to you with the next question. You mentioned around comorbidities and the question about how other conditions affect placental function, affect PlGF results, such as diabetes. Does it affect the interpretation of PlGF? So the evidence we have in Oxford is that it doesn't, it seems to be the markers seem to be certainly. Well,
I think they're very much specific to preeclampsia, and preeclampsia is driven, you can get more likely to have it with diabetes, but the pathology is the same, and therefore it works the same. And there's evidence that it doesn't matter about ethnicity, doesn't matter about your BMI. There's studies that have gone on in Asia where these tests work exactly the same. So in South Africa, in Japan, the thresholds are identical. So I think they're pretty translatable across the patch. Jenny?
Yes, that's brilliant.
Agree?
Yeah, absolutely. I mean, I certainly agree in the diabetes situation. I mean, making a diagnosis of preeclampsia in a woman with complicated diabetes is really very, very difficult, and particularly when fetal growth is also quite difficult to interpret, often in the context of maternal diabetes. So I think the tests are invaluable in assessing, preeclampsia as Manu says, there's a specific condition which is caused by placental damage in women with diabetes. There may be that in women with severe kidney disease that the levels of the hormones may be slightly different, and there is some evidence to suggest that PlGF level concentrations might be slightly higher in women with severe kidney disease who've got preeclampsia. But nonetheless, the tests are still extremely useful, even if you allow for a slightly higher threshold of PlGF and interpret the ratio test in the context of a woman's kidney function. These blood tests are extremely useful in women with all comorbidities, cardiac conditions, diabetes, lots of conditions where changes may look like they might be heading towards preeclampsia, and the test really helps to make that specific diagnosis and really alters the way you manage that pregnancy.
Wonderful, thank you. There was one question as well about the testing, using the test with women postnatally, and whether to determine whether a woman could be discharged or monitored closely. Has that been tested at all?
So when you deliver the placenta, the hormone levels revert back to normal very, very quickly. So the soluble FLT level particularly plummets very quickly in the first 24-48 hours after delivery because the placenta has been removed. The tests do look slightly different in the first 24-48 hours in women who've had preeclampsia, but I don't think they would help us to determine postnatal management. I wonder if Manu's shaking his head. I think so. Certainly, my view is that they're not going to be useful, sadly, for helping with that early postnatal management and blood pressure management.
Marvellous, thank you. I'm going to move on. There's a few questions around costs and economics, health economics here. A couple of people have asked about the cost of the PlGF testing, including for areas that are not covered by medtech system. And then an associated question, how often will the test need to be carried out? So obviously getting a whole sense of the testing costs there. And then otherwise, what are the financial outcomes with PlGF versus a split PlGF ratio? Which is better in terms of people finances for the unit? I wondered, Andrew, if I could direct those questions to you in all of them.
Hi, it's Andy Shannon here. I hope you can hear me. I'm on my phone here because my computer wouldn't work. So I'm actually here as APEC chair and chairing with Marcus, but I have an interest in this area and so I'm very passionate about it. I think answering the question, the obvious question, which is the PlGF versus the ratio, the bottom line is all the companies that currently produce these markers are about the same. We've done studies showing that they're all very equivalent. And actually the cost savings are very clear on all products. I did see an email today saying one company categorically saying their product was better than everyone else's and you shouldn't compare them. I don't think that's right. I think we have a bit of a problem because they have different levels and we have to make decisions about what we use. But at the moment, the ratio and the PlGF are very similar in their ability to rule out the disease. And nice considering the other companies that have products on the market, which on in research look like they're very equivalent. So the cost savings are very clear on all products. And I think it depends what you're familiar with in terms of making a decision what you go with. But it's very exciting that we have a new product that saves money as well as improving care. And that's a great position to be in with these products.
Jenny, did you want to follow up on that?
Well, it was just to agree with Andy really, and to say that you know, the tests, the companies that are providing the tests where the performance looks almost, you know, the diagnostic performance is almost identical in terms of the way that the tests have been marked, although the actual numbers that we use to make rule in and rule out are different, but their diagnostic performance has been shown to be very comparable in all the studies. And the companies have to make them pretty equitable in terms of pricing, otherwise it's not going to work. And hopefully the more companies that we have making tests, the better that is for all of us, because it will help to drive the costs down. So it's great that we've got more than one test available. We certainly don't have data to suggest that one test is better than another, and their ability to rule in and rule out is very comparable. And so as just to echo that, and the costs hopefully will continue to come down as more tests become available, more companies become available.
Thank you, Guy.
Yeah, just to sort of build on Jenny's point. So I've been involved in a number of business cases over the years for various trusts, but there's more to it than just the purchase cost from the manufacturers. There's also the internal costs to consider as well. So the answer is almost how long is a piece of string. So when you're working out the true cost of a test, you need to know not only what the test is costing to procure, but what the internal overheads are for delivery of that test as well, because that can vary enormously from trust to trust, depending on how the labs are funded, which part of the country, and so on. So it's a complicated equation.
Wonderful. There are a couple more. Oh, Natalie, do you want to? Sorry.
I was just going to add as well, if you're interested in the overall cost savings from an NHS perspective, the actual figures are contained within the medtech policy, which I know APEC are going to share. I'm just looking at the policy now, and it's on page 31 in Annex 2. So if you're interested in looking at the estimated cost savings up to year 5, they're all included within that.
Wonderful. Thank you very much. The little boy just wants to go to bed. About time. If I can pass over to Andrew to as a summary and a thanks, and I'm going to put off my camera and go and get someone to bed.
That's a very timely entrance. Congratulations, I can say. Can I just say, look, thank you, everyone. It is so good to hear the wider perspective here, particularly the patient perspective. I can't stress how much this means to patients, the reassurance, the help in their management. And it's great to hear those stories, as well as the bigger picture around the policy and the implementation side of this. And I think we're leading the world really in rolling this out around the UK and kind of trailblazing in terms of what everyone else should be doing. So I think we can be very proud of what's been achieved, and the collaboration between commercial interest, NHS and all the regulatory authorities, I think is a real exemplar of a successful story. I think APEC is particularly keen on supporting any venture that helps women, and there's no doubt that these antigenic markers have been a huge advance in improving both the management and many other aspects of care related to preeclampsia. And just to say thank you to everyone who's been involved in this, and watch the space. We will, move forward. The NICE guidelines are being re-looked at, and again, just to emphasise, we are leading the world in blazing the way. Marcus, can I thank you for organising this along with your team, Rowan, and so on. And for everyone attending. There have been hundreds of people on the interest, and thank everybody and the panelists, all the speakers for their contribution, for spending your time with us.
Thanks very much, Andy. If I can just finish off as well, just say thank you to everybody who's been here. We've had several hundred people on the call this evening, both watching here and live on YouTube. So thank you all very much for that. I recognise there are a few questions that we haven't got to and haven't got answers to. What we'll do in the next couple of weeks is get a Q&A up on our website, and we'll let you know when that's up. We'll also be sending a feedback form out to you tomorrow, so please feel free to return that. We only learn from hearing from you about what's worked and what hasn't worked, so please do keep in touch, and thank you all very much.
Thank you. And likewise, just on behalf of the Innovation Research and Life Sciences Group at NHS England and NHS Improvement, thank you so much, everyone who's working on this, and all of the patients, and everyone who's given up your time and joined this evening.
The recording has stopped.
Thank you all. Let's call it quits for the evening, and look forward to seeing you all soon.
Thank you.
Thanks, everyone.
Bye.
Thanks, everyone. Speak to you soon.
Bye.
Bye.
Bye.